I wanted to ask him about going back to the hypomethylating agents where we heard a lot of things. Would like to ask you, give us a picture, the typical picture of the patient that you would treat with hypomethylating agents who presents to your practice with myelodysplastic syndrome. What does this patient look like?
Well, I mean, certainly following the AZA-001 trial data, I propose almost every patient that has high risk and will accept hypomethylating agents for treatment. So I make a conscious effort not to make any restrictions in terms of age, even comorbidities. And the only restriction really that I end up by having is the patient's own decision. And we've been talking a lot these days about ageism and how doctors have an ageism factor, but I think a lot of patients have that factor as well. I have a few patients, not the majority, but a few patients who refuse bone marrows because they feel it's too aggressive and they're too old for that. A few patients who refuse hypomethylating treatment because they don't want to come to the hospital to receive the treatment. In Portugal, we cannot deliver it at home. So that is difficult. But most of my patients are around 60, 65. That's the majority. I must point out I work in a tertiary referral center. It's an oncology institute. So I probably have a selection bias of who is sent to me. But they're 60, 65, transfusion dependent, and with high-risk MDS as per IPSS, which is what I use.
Norbert, can I ask you from your point of view, if you have a younger patient, so say 58, who presents to you with higher risk MDS, and he's eligible for azacytidine treatment, would you start him right away, keeping in mind that you might transplant the patient? Or would you, are there some patients where you would say, well, here I go rather for an intensive therapy and following with allogeneic stem cell transplantation? Or do you put azacitidine always even before allogeneic stem cell transplantation?
That's precisely I agree, I fully agree with you. So to me, there are very few patients who are not eligible for azacitidine when they are high-risk MDS as a frontline treatment. And maybe the exception are the patients, the youngest patients who could get a transplant, because we have to remind that in the AZA-001 study, the response rate for the patient treated intensively was higher than with using conventional AML criteria, was superior to azacitidine. And that in the survival difference was difficult to assess in this group due to the small number of patients. So we still think that an AML type treatment for patients less than 60, let's say, with no comorbidity, with a donor for allogeneic transplant is advisable.
Okay. Antonello, if I can just follow up on this. We have criteria, IWG criteria for the response. But here with the hypomethylating agents, we run into a problem. How are we going to solve this? I mean, I treat the patients with hypomethylating agents with intensive therapy, and then after 3 courses, IWG doesn't help me because there's no response whatsoever. But then, as you showed yourself, after 6, 8, or even 12 cycles, I might get a response. So is IWG dead?
I think that IWG needs to be changed according to the last result of the trial. The basic concepts which were behind, the response criteria, I think still holds based on the clinical trial data. As every dynamic classification or criteria, this needs to be updated based on result of trials. We now know, as I showed you before, that not only time to first response keeps a lot of time upon treatment with DNA methylase inhibitors, but also that the first response is not necessarily the best response. So I think that more than a clinical problem, we have a problem of cost effectiveness of therapy first. And the second issue is, and I think is very important, that at least according to my everyday experience, one of the most important risk factors for older MDS patient is not the chronological age, it's not the likelihood to respond to DNA hypomethylations, but it's the logistics and the family. In other words, still we have to face the idea that gaining 1 year of survival in a 77-year-old patient is not the same, it's not of the same value than getting that improving survival of the same 1 year in a younger patient. This is the first issue. So it's sort of cultural problem. And the second problem is that you have resistance also sometimes from the family, because the logistics of current way of administering DNA hypomethylatus is complicated. So the family will tell you, oh, doctor, I have to keep my granny every day for 7 days to the outpatient clinic, and then so on. So, I mean, once we found a way to move treatment home, then I think that the problem of treating very old people with MDS will be solved, or if we find out oral DNA inhibitors of DNAP-T.
Thank you. Valeria,
Yeah.
can I bring you into this discussion by asking you one thing? There were data shown that prior therapy was a prognostic factor in AZA for patients treated with azacytidine.
Yeah.
So does that mean that it's better to treat them early with azacytidine, or would you say, you know, it's still reasonable to try different treatments, and then when nothing works, then come in and do azacytidine with them?
No, I don't think so. The French data are showing quite clearly that if you come with azacytidine after previous therapy, you don't do so well as when you use it de novo. And then as I must say, it's quite evident that the efficacy of azacytidine is higher than low-dose RC or the supportive care or other options. So I do not think we have to postpone treatment. There is only one case in which I cannot answer you because I really don't know, and there is no evidence about it, is that when a patient has a bad marrow but very mild cytopenias, we still don't have evidence whether we have to start immediately or wait for a while. This is something we should study because I think it's quite important. Maybe we can even slow progression in this patient by starting earlier. And I think I wouldn't doubt in starting. But listening to the data that, and the thinking of Antonello, this is a question I have for our three experts. How much do you think we assess, and how accurate you think is the assessment of response in real life? So not really thinking of how it should be, but how it is. Because we see very often that only hematological improvement is evaluated and not really the bone marrow response. So.
Norbert, do you do cytogenetic analysis every 6 months in your patients?
Yes, I do.
You do that?
Yeah.
Would you advise everybody to do it?
Yes, because besides the response, the diagnosis of response, we also have to keep in mind that some patients could progress under treatment, and so we also have to be able to pick up these patients and so find signs of disease progression. So I think that a complete evaluation is necessary.
Antonio, how do you check on your patients who are on hypomethylating agents? Do you see them, do you do 6 monthly bone marrows on them, or do you discuss this with them? You know, especially in the very elderly patient, as Antonello just pointed out, it may be difficult to bring them to the hospital all the time, and bone marrows may be really difficult in an 80, 85-year-old. They don't like it. What is your way? What is a way of dealing with that?
Yes, no, they don't like it at all. And especially they don't like me when I propose it. So the relationship becomes difficult. I must say, I naturally have a bone marrow prior to starting therapy. And as a hospital policy, we have instituted that we do bone marrow after 6 cycles, whether or not they have a hematological response, to try and assess some sort of response. Most patients will not want one after that unless they have disease progression or they lose response. once they lose response, I do encourage them to have a bone marrow to see what's happening and to see whether they still have a lot of blasts and maybe there's no point in trying growth factors. But if they have few blasts, then growth factors might actually help in those situations. But I do very much direct, in this real life setting outside of clinical trials, direct my bone marrows in terms of providing some sort of therapeutic guidance rather than just to assess the marrows. And I think it is difficult. We cover a large area and quite a few patients come from far away. So that extra visit for a bone marrow is particularly burdensome for them and they don't want it.
Agreed. Valeria, finally, one question. Is there any point in stopping hypomethylating agent treatment in a patient who is on?
Reimbursement? No, we don't stop. In our center, we go on until progression. As we discussed very long this morning, I think we will have to set some points for that as well, because I have patients treated for years, and Lou Silverman, who has started the first, has patients treated for 12 or 13 years. But of course, this is something we should really look upon.
In my personal experience, many patients come up to me and say, do I need to take it every 4 weeks? Can't I take it every 5 or 6 weeks? Do you do things like that? Or are you a very strict person shouting at your patient and saying, you come back to me every 4 weeks?
No, as you know me, I'm not a very strict person.
That's true.
Now, what we usually do as a policy, when a patient has reached a very stable response, and we do assess with bone marrow and hematological situation as well, we tend to delay cycles, but this happens after 1.5 years or 1 year, and we are really sure that the response is stable.
And delaying is 6 weeks?
Delaying is 6, sometimes after a couple of years or 3 years, 8 weeks, but this is rather risky, I must tell you, in my experience.